Suicide is the second leading cause of death for young people ages 15 to 19, according to the Centers for Disease Control. The most common method of suicide in the United States is a firearm. A UMass professor is looking at how pediatricians in routine office visits can offer parents tips on gun safety and even gun locks as part of a universal prevention strategy. John Zeber is a mental health services researcher and associate professor in the Department of Health Promotion and Policy at UMass. Carolee McGrath sat down with him to learn more.
Well, sure, this is an ongoing project, so I first need to thank my friend and colleague, Dr. Ann Davis at the University of Pennsylvania. She's put together an amazing team of mental health researchers, implementation experts, and methodologists to work primarily in this area. So she's been doing this for a couple of years. It all started when she reported, unfortunately, a tragic case that happened in 2015. A young man named Cayman, having some stress at school, came home from school one day, went into his house, retrieved a gun, and went into the woods behind his house and unfortunately tragically ended his life. It's not uncommon. There's over 5,000 suicide deaths in the age group between 15 and 24 every year. It's the second leading cause of death in this age group, so it's a very prevalent, significant, serious situation. So Renee wanted to study this issue. She approached Dr. Greg Simon, who's the leader of the Mental Health Research Network, a national coalition of 13 large integrated healthcare systems, several of the Kaisers, Harvard Pilgrim, others. And we had 2 volunteers to join this pilot study. Myself, which was in Texas at this time at Baylor Scott & White, a large healthcare system. And we also recruited our friend Brian Amadani at Henry Ford Healthcare System in Detroit. We tried to get a mix of sites. Henry Ford is primarily an urban setting. Texas is, where I am, is muchly a semi-rural, right, in the central Texas area. We also wanted a diversity of political climate, people, rural and geographic settings, so it was a good mix there. The pilot study involved a couple of phases. One was to really get the sense of the safety component checklist that you mentioned. There was a 2008 article published by Barkin and colleagues that demonstrated the success of using this component in safety check within overall primary care. And the 3 components are simply doing some basic screening about the availability of a gun in the house. Secondly, doing some brief counseling about safe storage of firearms. And third, at least offering provision of gun locks to your patients. But it has not been tried in an adolescent population, so we wanted to see if we can adapt it. The first step was seeing the acceptability of this in these 2 large healthcare systems and then seeing if we can do something to actually implement it.
How do pediatricians feel about this, who you've worked with? Because obviously when the child comes in for a well visit and it's their physical and they're looking at, growth charts and height and weight and all of the other things, this is one more layer, to do that they have to put on their list.
Well, that was the interesting finding about this study we did. We first gave surveys to about 140 primary care physicians. And then we did some follow-up in-depth interviews at both sites with clinical leaders, pediatricians, nurses, gun constituents, families. And what we're finding is there's an acceptability to doing a lot of this. Doctors already speak to their patients about many safety issues and public health issues. There was certainly a willingness, and many of them already do talk about at least a couple of components of that safety check. Do you have a gun in the home, and are you practicing safe storage? Where some of the differences we found in hesitation were actually the provision of the gun locks. There was more concern about actually doing that. Some was simply the logistics, storing hundreds of these gun locks in their office. Others are concerns about potential liability and having training to how to use them and what would happen.
Which is a big issue, too. I mean, if you say, well, I got this gun lock from my pediatrician, and, God forbid something happened, I'm sure they would feel really worried about that.
There was at least some concern about the legality and the ramifications of that, certainly. But there are also the time involved. One more step, not just asking questions, but going out and giving one and training about this gun lock. So while there was an overall acceptability of these 3 safety components, whether or not it was specifically targeted to high-risk, depressed youth or overall, which is what we're advocating, a more universal approach, some of the practical concerns do need to be overcome and thought about a little bit as we're taking our next steps in this research.
And why not just leave this to the mental health professionals as opposed to a pediatrician?
That's a great point. Mostly, of course, families and most kids do actually see their primary care physician far more often than are actually in mental health. There is still, even though there's an increasing integration of mental health and primary care, there are still separate systems. Often the clinics are far apart. There's not a great communication between them. And simply the opportunity is much more prevalent within primary care. The parents are often there. They come with them to discuss other issues. This is a perfect opportunity for a universal precaution to address this issue there.
Okay, and I know that you wrote that this research doesn't take a position on gun ownership, but people might be uncomfortable. Parents who have a gun in their house, maybe they're in law enforcement, former military, might feel perhaps that the doctor is interrogating them or maybe even shaming them, for having a firearm in the house because it's so controversial.
That's an interesting point, and that's one reason we chose Texas to begin with, is there was a law in 2014 that was percolating through the legislature to actually forbid doctors from doing this. We're glad it stalled in committee, never went anywhere, but it does raise that specter of some concern from both sides. And there have been patients who have been threatened, as you mentioned, or threatened to sue doctors for approaching this issue with them. But most of the time, at least in this pilot study, we found no differences in sight between providers' willingness and even the patient's willingness to participate in at least these simple measures that can be done within a primary care setting. It did not feel overly threatening or imposing, at least from our pilot study results.
And so where do you hope to go from here with this research?
Well, Dr. Bates and colleagues, we're working on an intervention proposal right now to submit to the National Institute of Mental Health, trying to expand from the 2 sites to perhaps 3 or 4, maybe 5, if we can do that, to actually take it out into community settings, perhaps at UMass Worcester clinics or elsewhere, and to actually try one or more of these safety components. We're still developing the specific nature of it, based on the pilot results of what might be feasible or not. But if we can try to do between one and all of these safety components within an actual setting, that'll be the next goal. Examine the barriers to implementation. Also measure, does it have an impact on suicidal attempts, threats, other safety issues, plus the general satisfaction to see if we can get patients and doctors to agree this is a public health issue and it's worth addressing in some finite, concrete way.